Our first speaker, our keynote speaker, is Dr. Ananthi Krishnamoorthy. She is a medical doctor with diverse experience in rehabilitation medicine, primary care, and occupational health. She is certified by the Society for the Advancement of Patient Blood Management, or SABM, on the fundamental and advanced concepts of patient blood management. She has a varied career, including stints at the Blood Management Center in the United States at St. Luke's Hospital in Kansas City, the Center for Bloodless Medicine and Surgery in Penn Medicine, University of Philadelphia, Pennsylvania in the United States. She also is a published author in the Medical Journal Malaysia. So again, we're going around the world, and is a collaborator for the manuscript, A Global Definition of Patient Blood Management. And this was published in the prestigious Journal of Anesthesia in February 2022. She has been actively involved in organizing patient blood management conferences in Asia, which is so important. Again, being a diverse audience and getting this word out. And she seeks to promote the superiority of patient blood management, bloodless medicine to everyone. She's also a past secretary of the Malaysian Society for the Patient Blood Management and the current secretary of the Bloodless Medicine and Surgical Society. So now we are going to go to Malaysia to hear this keynote address, Bloodless Medicine and Surgery, the bridge to recovering what is lost.
Thank you very much, Yvette, and also Dr. Kawamoto and everyone in BMSS and everyone here. So today I will be presenting on bloodless medicine and surgery, the bridge to recovering what is lost. So we're just going to see some outline and see what it's all about, right? So the outline is what is actually lost and what are the lessons that we can gain from the pioneer and what was actually recovered and what is the future direction. Okay, so we're going to learn actually from a lesson from a real life example. You know, they always say that our patients are the best book in that sense. So we can learn a lot from our patients. So this is one young lady. She's a 26-year-old. And in October 2018, she presented with lethargy and decreased effort tolerance for 6 months. She was actually seen in the medical clinic. Upon further questioning, they noted that she had irregular menses and also menorrhagia. But I think previously she was on oral hematinics and she was not able to comply to it. I guess a lot of people would know it's not easy to be compliant to oral hematinics. Her hemoglobin at that time was 7.3. And the T-set, transferrin saturation, was 3%. So just looking at these two levels, we know that it indicates iron deficiency anemia. However, in this case, they did do quite a number of extensive tests, including like, full blood picture and others, you know, even to the point of considering HB analysis. But yeah, actually, when we just consider this history, we can actually come to the conclusion that she actually had iron deficiency anemia. It's interesting to note of the options of treatment that was offered to her. In this case, it was a chronic stable anemia, and this patient was offered a blood transfusion. And since she wasn't keen, then the other option that was offered to her was oral hematinics. So that was at that time. And in later couple of years' time, of course, in between, she did have some blood tests done. As we can see in the graph, in July 2019, interestingly, her hemoglobin had gone up to 15. Likely at that time, her menses were a bit better controlled, and also that she might have been better, having a better diet, and also probably is really compliant to oral hematinix. It's quite interesting. So, however, the ferritin test around like when her HB was 15 or 13, her ferritin levels were actually very low. I did not include it here, but it was actually below 10. So that is an interesting point to note. In December 2020, she actually had menorrhagia for 3 weeks. And she again presented with lethargy and dizziness and decreased effort tolerance. Now, this is considering 3 weeks of menorrhagia. And look at what has happened to her hemoglobin. At this time is 5.6. And the MCV at that time is 68. And this young lady, she was actually able to walk around, and she has been at home. And the main indication that she was actually told to have the urgency of transfusion was that, yes, one is her HB is below the trigger, the usual trigger that we all hear about. And the other thing was that she was feeling lethargic and decreased effort tolerance. So the reason that she was told that she needs a transfusion is that there might be a risk of cardiovascular compromise. So we need to look at that again, right? Yeah. So anyway, in this case, this patient was not a bloodless patient. And so she did listen to her clinicians and she was given transfusion. And subsequently, she was also discharged with oral hematinix. And she was also given OCP, oral contraceptive pills. Now, if we look at the graph again, we can see that the hemoglobin progression, she was discharged with a HB of around 10. That was like 1 or 2 days after transfusion. And so after that, a few months later, and even up to 10 months later, her hemoglobin is still around 10, right? So again, we can see that this is not really an optimal treatment. And this is something that we can learn, that she has actually lost something, right? So what are the aspects that has been lost when we actually see treatment in this kind of case? So we need to see, right? Actually, in few areas, actually each area we actually lose something if we did not practice bloodless medicine and surgery, right? So in the medical field, when a bloodless medicine is not practiced, in that sense, because the medical field finds that blood is easily replaceable, right, with something from an external blood bag, right? So in that sense, the true value of the blood that is in the patient is actually lost, right? So this is something that is lost. As for the healthcare professional, what actually do they lose? It's interesting because when we know that there's something that is so easily available that I can replace easily, if I need to conduct a surgery, I know that I can hang on in case there is excessive bleed. I can still transfuse the patient. So I do not need to perfect my skills for a meticulous surgery. In that sense, I will lose, right? So, and then if I know that there is this blood is easily replaceable, then I do not improve on my adaptability or teamwork. So these are skills that is actually lost. As for the patient and the family, because they are not given much options, right? It's either transfusion or no treatment, or it's just oral iron, right? So the thing is, the tendency for the current practice is that to have a paternalistic kind of behavior. And so in that sense, the patient empowerment or the right to choose, make an informed choice is actually lost. We will learn about it later. I believe Cassandra will be presenting on that. Yeah. And as for the patient also, because the health is now not optimized, as we can see in the patient, the hemoglobin was just, it did not reach to optimal levels. Transfusion, it just probably gives a temporary relief, or, it's kind of probably a relief to the clinician. However, it does not really produce a lasting and sustainable result. And so in this case, this patient is actually having her health and productivity affected. As we can see, she did come to emergency a couple of times after. I think in that case, she had symptoms of palpitation or, hyperventilation. So we do not know whether does that have anything to do with her iron deficiency or anemia, right? So in that sense, she actually loses her optimal health. She loses her productivity. As for the community, what do they lose, right? So if we do not treat our patients optimally, then our population health is actually suffers, right? So generally, the patients that we treat are not optimal. They're not really healthy. And so that will actually also affect the economic prosperity. So there's actually a lot to lose if we did not really value or put the value in the right place, right? So just looking at this picture, you want to see which is actually more valuable, the image or the real substance. Well, we can see the mountain, right? And we see the image, right? But again, we remember the image is just an image, right? So we need to think of where is the right, which is more valuable, whether the blood that is in the patient or the blood that is in the blood bag, right? Okay, so let's see more. So again, in this patient, right, so her health is suboptimal, so she can undergo like mental and physical health problems. And that again, as we know, anemia increases morbidity. Her quality of life, symptoms of iron deficiency and anemia will definitely affect participation in daily activities and social life. So, this is a nice table or nice kind of the journey of ferritin, right? So we see, actually got this reference from ironsweets.com. So they have a clinic in Singapore. So, but it's very interesting to see with the dropping of ferritin levels, there is a lot of symptoms that we actually undergo. And so in a person which has anemia, by that time, the ferritin is already depleted. And we can think of all the symptoms that a patient or a person would actually undergo. Like we think hair loss is normal in females, but it's actually not normal. Yeah, and fatigue, we can't really say that a lot of us feel fatigue, but whether is it really due to iron deficiency? And so all of this will actually limit our daily activities as well as limit the social life in a young person or even right to someone who is much older. And definitely work performance and productivity is also affected. So again, plenty is lost if we did not really optimally treat the patient. And again, we're talking about population, right? So this is a WHO document. This was the policy brief from the World Health Organization. And so here it mentions that 1.95 to 2.36 billion people are estimated they're actually having anemia, and more than 1.2 to 1.4 are also iron deficient. So think of that one patient with all the symptoms that she has and multiply that with 3 billion, right? So it's just one person that we actually see with all those symptoms and all those effects, because we do not see everyone all together at one go, but we're looking at now the breadth and also the depth of the problem. So it's really a huge loss if this condition is not properly addressed. Again, this is a study done among Swiss women. So they have mentioned about the economic burden of symptomatic iron deficiency. The unfortunate thing is a lot of these women, they are actually iron deficient. However, they are misdiagnosed as having depression, burnout, anxiety, chronic fatigue, right? So these are all symptoms can be attributed to iron deficiency. However, because they are misdiagnosed, and so they get treatment for something that is not appropriate. And so again, there's a lot of cost and burden. Also, we see that a lot of them usually say that they are exhausted right? And have sleep disorders, depressed. Yeah, so there's plenty of negative things, right, that we see. So again, we can think about the sheer scope of this problem. Right, now this was something just done locally in the hospital that I work in, just because I work in the occupational safety and health. I just come across certain staff who have some symptoms. And so we did look at a ferritin test done across 2 months. And I took a sample of 15 people. And it's interesting, out of 15 people, 14 had suboptimal ferritin levels, right? So if we want to say iron deficiency, we have 12 people actually having iron deficiency, 12 out of 15 out of, the ferritin test that we did. So it really seems that plenty of people are actually having this problem. Now, here again, the question comes about, does absence of anemia exclude iron deficiency? We always say that, okay, if the HB is normal, then it's fine. In the same group of people, we see that even those with HB of 13, 14, 12, the ferritin levels are low. So actually, even all these people are actually still having a lot of symptoms and burden in their lives daily, right? So again, these are among the things that is lost. Okay, so we've heard a lot of things that is lost, right? Now we look at what can we learn from a pioneer, right? Yvette was also just mentioning about this special person, Dr. Denton Cooley. And so, yes, definitely he is the pioneer for bloodless medicine and surgery. And the thing is, I just came across this LinkedIn post by Texas Heart Institute. It's quite interesting. So yes, they do recognize that he is the one who actually contributed to the development of bloodless surgery. And that was in 1962. And hence, again, is a Bloodless Surgery Day is actually commemorated on May 16. And yeah, so this week is the one that we actually celebrate or remember as a Bloodless Medicine and Surgery Week. And here we are learning about this superior medicine. So Dr. Denton Cooley was known for being versatile, and he's a masterful surgeon. And he was responsible for numerous discoveries in the surgical and cardiothoracic field. And in May 1962, he performed the world's first bloodless open heart surgery on a Jehovah's Witness. And we know that for a Jehovah's Witness, blood is not an option. And within a year, he did 6 more cases. And for many years, he was the only surgeon who was willing to operate on this group of patients. So in this case, here we see the start of bloodless medicine and surgery. And it's interesting that it is actually started by someone who is very notable, charismatic, and very masterful person, right? So we will learn more. This is actually a newspaper cutting. I just found it also today. It's in 1977, San Antonio Star. So it mentions about top doctors performing heart surgery, right, without blood transfusion. And some of the points that I found interesting, I think even in 1977, there's a doctor called Dr. Kenneth Riegel. He actually mentioned this point, that blood is more uniquely individual than a fingerprint, and it is like an organ transplant. So this is something that we all echo now, right? And yeah, 1977, that was when he mentioned that. And I believe it is something that we really need to keep in mind, again, the way that we really think of blood, and to really treat it with respect that it deserves, right? And again, cardiovascular operations can be performed safely without blood transfusion. This was from the study from Dr. David Ott and Dr. Denton Cooley. Right here, they actually presented 500 over cases, right? Jehovah's Witnesses, successful open heart surgeries. And this is about 20 years of experience. I'm talking about consecutive series of 542 Jehovah's Witness patients. And look at the age range, 1 day to 89 years. So if they can do it then, in 1977, we have to think, is there an excuse not to do it today, right? So if we can learn very much from these great pioneers, then definitely we can actually improve as well. So what are the qualities that Dr. Denton Cooley has, right? Amazing qualities. One of it is he was actually curious and he is actually having a progressive mind. So at that time, he was faced with an obstacle, I believe. In that time, it was mentioned that it was difficult to look for blood to be part of the prime in open heart surgery. And so they had to look for non-blood prime because there was a shortage of blood. And also there was an issue about safety. Hence, that is why he and his colleague, Dr. David Ott, actually, they both worked together and pursued this work of producing non-blood prime. So in this case, it's also interesting to think of the lesson that sometimes we actually face now. Even locally, we have shortage of blood. And so what happens is when there's a shortage of blood for transfusion, what goes more is actually blood donation drive to actually ask people to donate more, right? But if we can start to think like Dr. Denton Cooley, if we know there is issue with shortage, there is issue with safety, are we able to do something else which provides better outcome and reduces cost, just like what he did, right? Instead of asking for more donation, right? The other thing that he has is skillful hands. We know that he's very good with his hands and he operates very quick and he has less blood loss, right? So that, of course, provides for successful bloodless surgery. And he has also empathetic and willing heart. So he is actually moved to respect patient wishes and he wants to help people. And so he is willing to go beyond what is needed at times to actually do what the patient needs, right? So these are definitely a combination of very beautiful qualities. So he's a pioneer of bloodless medicine and surgery, and we see many of replicas, right, among all of you here. And so we see that many of the ones here have helped so many people, just like what Dr. Denton Cooley has done, right? Okay, so now we go back to, since we have learned now what is lost, and we learn from the example of the pioneer, we can see the contrast from another patient with similar problems. This patient is actually a 20-year-old. She didn't have any comorbidities. She also presented with menorrhagia. Her hemoglobin was 6, and then it dropped to 4.9, and the lowest was 3.6. And in this case, this patient did not receive any blood transfusion because in this patient, blood was not an option for her. And what is the difference, right? In this case, just like how when faced with obstacles, we are able to overcome it because we know that the other road is already closed, right? So we don't say it's the total roadblock. But in this case, yes, this patient received intravenous iron. She received tranexamic acid to control the bleeding as well as oral contraceptive pill. And at the time when her hemoglobin was low, she was also supported with supplemental oxygen. She was asked for bed rest and also protected with the proton pump inhibitor for her gastric to prevent any gastric bleeding. So look at the evolution of her hemoglobin. We noticed that it dropped right to 3.6, so that was the lowest. And at that time, we did not have high dose iron, so we gave her this another iron, which is iron sucrose. And so we noticed that her hemoglobin continued to rise, right? And it was actually sustained even up to 1 year later, right? So this is a contrast as to what the other patient had. So sometimes we always hear clinicians may say that if you do not have blood transfusion, you will die. Yeah, in this case, the one who had a blood transfusion did not receive optimal health outcomes. And the one who did not receive a transfusion, the one who did not receive a transfusion gets better health outcome as compared to the one who got a transfusion. She did not get an optimal outcome. So it really debunks the myths or the kind of hearsay that we hear, right? And so we again have to look at evidence. And I believe many others have also presented similar things, that we have seen that patients who are having bloodless medicine and surgery treatment, they actually do better, and they actually have long and sustained good results. Okay, so whatever that was lost earlier is actually recovered in this case, right? So we see the true value of blood. So the patient, actually in this case, because the patient does not accept an allogenic blood transfusion, so they really have to value her own blood. And so they did not have any much of blood taking in this patient as well. So phlebotomy loss is actually minimal. And then they try to optimize her own blood. So in this case, her own blood was actually valuable. And in this case too, the doctors who are treating her actually learned to adapt better, and they had to have a lot of teamwork. They have to work with ONG hematologists. Yeah, and so they did actually have good teamwork. And in this patient, she did have her right to choose, and it did give her better outcome and improved productivity. Right, again, we're coming to the point of which is more valuable. Again, we see that with bloodless medicine and surgery, then the focus is on the right area. Okay, so what is the future direction? The WHO actually did have a document on anemia, and there was a caption that they mentioned. It says that it is estimated that for every $1 that is invested in reducing anemia in women, $12 in economic returns could potentially be produced. So isn't that interesting? With very little that we actually put in, by really valuing the blood that is in the patient, improving anemia, treating it optimally, then we can get 12 times of what we actually put in, right? Yeah, so we need to really, again, our future direction, actually it has already happened in the past with Dr. Denton Cooley, right? So we need to re-establish and remember that and continue on, right? To recognize the true value of blood. The blood that is, as what a lot of us have heard, the blood that is in the patient is the one that is most valuable. So we want to cherish and protect and implement strategies that promote blood health. So this is a point that also many of you are also promoting and championing, as well as I believe in the book Blood Works, right? So we can learn a lot about blood health. Yeah, so this is actually the future, right? And bloodless medicine and surgery should be a standard, not just limited to a certain group of people, because we know the benefits are actually really good for all. And so it should be standard so that everyone can actually benefit from good health and superior knowledge and skills. Okay, that's it for now. I'd like to acknowledge everyone who have contributed to my growth. Thank you very much.